Inflammation is really important, and it is one of the leading causes of all cardiovascular disease. There was an article in Lancet which compared the mortality diseases which caused death in India in 1993 versus in 2010. Let me tell you, the leading cause of death in 1992 and before was tuberculosis, and in 2010 and beyond it is cardiovascular disease. By 2020, 1 out of every 3 heart disease patients in the entire world will be Indian. I think that is not a thing of anything to be proud about. But we all know about epidemiology of heart disease, diabetes, lipids, hypertension, behavioral diseases, demography, genetic. They all contribute to cardiovascular disease. And globally, it accounts for 31% of mortality, and in India it accounts for 28% of mortality. I would expect some participation in this one question which I'm going to ask now. How many of you think that being an Indian is a risk factor for heart disease? 1, 2, 3, 4, 5, 6. Let me tell you, being an Indian is a risk factor for heart disease because heart diseases in Indian population occurs a decade earlier compared to the Western population. The youngest patient on whom I have done a PCI was 22-year-old resident of Gurgaon who used to work in an MNC, and he was an Indian. And the eldest person I have done an intervention was a 97-year-old American lady who used to walk, live independently and do everything. So yes, being an Indian is a very high risk, is a risk factor for all cardiovascular diseases. So that is why the demography plays an important role. 12 to 16% of coronary artery disease patients are young. It happens below the age of 40 years. But I would say in Indians this number will be higher actually. This is not the Indian data. I would say almost 30 to 40% of all coronary artery disease patients in our country are below 40 to 45 years old. What do you think, sir? Right? Almost 30 to 40% of all patients. So, you must have encountered some of the patients in your clinical practice who say, sir, I don't even smoke, I don't have hypertension, I don't have diabetes, I'm not obese, I exercise every day, there is nobody in my family who had a heart disease, and still I got a heart attack. Right? We encounter such populations. So look at this number, 19% of patients who have cardiovascular event, they don't have any risk factor. So what do I mean by any risk factor? Yes, they don't have any traditional risk factor. So now this is going to lay some platform about inflammation. So they don't have any traditional risk factors. So 60% of those who develop coronary events have only one or even none of the traditional risk factors. More than half have either normal or mildly increased lipid values. So a very busy slide, but just want to show you. Here you can see a lipid plaque in the coronary artery, or for a matter of fact, any artery, and let's see what all is there inside this plaque. It's not only cholesterol. Look at this, is called a foam cell. So foam cell is a macrophage. When it ingests the oxidized LDL, it becomes a foam cell. And then there's a lot of inflammation. You'll see new blood vessels, collagen, endothelial cell, increased expression of adhesion molecules, matrix metalloproteinases, which kind of degrade the cap of an atherosclerotic plaque. So what you see here is, in summary, a lot of inflammation going on. So what happens, you have pro-inflammatory risk factors, release of interleukin-1, TNF-alpha, which really increases the C-reactive protein, SSA, serum amyloid associated protein, ICAM, and which are adhesive receptors, and all these things are expressed in the endothelium and blood vessels. Again, inflammation. So this is an interesting table. Basically, it is going to tell you which patient profile has increased levels of hsCRP. So hsCRP stands for highly sensitive C-reactive protein. So it is one of the markers by which we can assess the level of inflammation in the body. There are various different things, but this is the one which has been standardized, and there is no difference between hsCRP and CRP. It's just the CRP which is measured by a highly sensitive assay is called an hsCRP. So look at this table. Patients who have high blood pressure, who are obese, who smoke, who have diabetes, low HDL, estrogen hormone use, chronic infection, chronic inflammation. This is a patient profile who's going to have high level of inflammatory markers in the blood. On the right side, patients who consume moderate alcohol. That doesn't mean that I'm going to promote alcohol consumption here, but yes, moderate alcohol intake decreases the level of inflammation, exercise activity, weight loss, statins, fibrates, and niacin. They all decrease inflammation. Again, a very busy slide. Just to summarize here, it has been found in various studies that HSCRP level add to the prognostic outcome when it is added to the Framingham risk score and LDL level. So again, important for all cardiovascular disease. Well, you might be wondering, does targeting inflammation and its markers reduces cardiovascular disease endpoint? That's a very important question. I mean, we hear so many things, we talk about so many things, but to us as clinicians, we want evidence that if we reduce inflammation, are we really reducing any risk of cardiovascular disease? So it has been shown in multiple trials. They compared HSCRP, systolic blood pressure, total cholesterol, non-HDL cholesterol, and HSCRP was found to have strongest association with cardiovascular disease. So again, this is a slide from Jupiter trial. Those of you don't know about it, we'll just go to the inference. Look at the graph in red, which shows that patient whose HSCRP level was less than 1 milligram per liter had the least cardiovascular events compared to patients whose HSCRP level was more than 1 milligram per liter. Another slide. Patients who had high CRP and high LDL compared to patients who had low CRP and low LDL, the probability of event survival was less. What does that mean? Is patients who had high CRP, or in other words, had high inflammation inside their blood, the survival rate was less compared to patients whose CRP levels were low. So what is low CRP, high CRP, and intermediate CRP? So HSCRP levels less than 1 milligram per liter is considered low, 1 to 3 is intermediate, more than 3 is high. But suppose if you send a patient for HSCRP level and your level is more than 8 as per the latest Braunwald, that indicates that there's some sort of infection which is going on inside the body. So what you do is you treat that infection and repeat the HSCRP levels again after 2 weeks, because they can increase by 100-fold, 1,000-fold in any sort of ongoing infection. So do you get these HSCRP level in all the patients? So let me ask, how many of you get this test done? Anybody in the audience who gets? All right, definitely, sir. But sir, can you tell me in which patients do you get these levels done? What type of patients? So you get it done in your clinical practice, sir?
Sir, not routinely.
Yeah, that is my question. I'm definitely theoretical.
Sir, I'm Dr. Rahul. First of all, I want to congratulate on your wonderful presentation.
Thank you.
I just want to share some of my research work during my MD in CMC Vellore. I did research on basically cutaneous markers of coronary artery disease. Mm-hmm. I definitely support your the role of inflammation in atherosclerosis and your subsequently the coronary artery disease. We studied the cutaneous marker like androgenetic alopecia. This was one of his first study of its own kind, like first in the world. Like androgenetic alopecia, which is a patterned alopecia in a genetically predisposed men, which is very common. We found that more than 3 vertex and above is associated with coronary artery disease. How did we perform this? We actually we studied more than 200 patients who are admitted in cardiac ICU or through plant for angiogram, and before coronary angiogram we used to evaluate for dermatological examination, complete dermatological examination, and it was a completely blind study. And then another investigator will evaluate whether that has come as a single vessel disease or double vessel disease or triple vessel disease, or it has come as a normal angiogram. And we found that androgenetic alopecia, very high specificity and sensitivity if it is more than 3 vertex. And we studied we found in the literature that there is a common thing is the inflammation which is happening in both in the coronary artery disease as well as endogenetic alopecia. Very few dermatologists are using anti-inflammatory drugs in endogenetic alopecia. I use like tacrolimus, that is a calcineurin inhibitor, even topical corticosteroid, and I found wonderful results, which we are not getting with the conventional minoxidil. Similarly, we get lots of psoriatic patients. So there is the same TNF pathway, which is common in the atherosclerosis. So that is another factor which is supporting the inflammation in coronary artery disease. Beside that, we also studied thoracic hairs. That was that will be coming in the literature. We are going to publish it. That thoracic hair, the pattern of thoracic hair, if the thoracic hair is extending to the abdomen, we could not find out the reason, the molecular reason for that. It is associated with the more double vessel and triple vessel disease, rather than those patients who are having only periareolar hairs or they were hairless on the chest. Besides that, we also studied the Frank sign. That's I'm just adding because actually the most important point was the endogenetic alopecia, which has also got inflammation and coronary artery disease. The other thing which we can look in the patients which we want to find out that whether they are prone for coronary artery disease or not is the Frank sign, which is a crease, which is a linear crease in the ear lobule, as well as a preauricular crease. And we were surprised to see the results. We can even the grading of this Frank sign, that is the grade 1, 2, 3. We can also find that was actually matching with the results of coronary angiogram, that double vessel. If it was grade 2, we ourselves devised the grading of Frank sign. So we should look for Frank sign as well as the preauricular crease. Theory behind that was the end artery. Both are the end arteries. If the whatever is happening at the level of coronary arteries is happening at the end arteries of the ear lobule.
I think that
there's lots of things.
There's some fantastic
lots of things also, like corneal arcus we studied. We found that other negative markers were like acanthosis nigricans has nothing to do.
That's why what is going to happen in future is there will be a physician sitting or somebody, some doctor will be sitting there, will just look at the ear lobule and say two-vessel disease. You need 3 stents because you have a long crease. But that was fantastic result, Dr. Rahul. I totally agree with you. What is lacking in the literature is there is a positive correlation between inflammation and cardiovascular disease, for sure. But we're still waiting for strong evidence that treating inflammation does the incidence of cardiovascular disease goes down. So we are still waiting for that. I mean, definitely the company is coming with a new drug called curcumin. It's a fantastic medicine because it won't have many side effects. But let's see, what we can do is we can do some sort of post-marketing surveillance, maybe on 1,000 patients or whatever number of patients, and then follow up for next 5-10 years and look and kind of document, does the cardiovascular disease really goes down. So the ideal patient will be a diabetic patient who's 30-40-year-old, does not have any stent. So this can be compared, not in a patient, or maybe if a patient, another thing which was found is, if inflammation levels are high, those patients, I don't know what is the percentage, but they tend to have higher restenosis rate following stent implantation. But let me be clear here, this data is from first generation drug-eluting stents. Now the third generation drug-eluting stents, the technology is so fantastic, as Sir would agree, I don't think it will affect. But definitely it's food for thought, and it can be worked upon.
Sure, sir.
Sir, any of your comments,
Yeah.
sir?
Thank you, Dr. Rao, for an excellent presentation and emphasizing the fact that the coronary artery disease is an inflammatory process. The clinical implication of all these things, once we understand that the basic culprit for coronary artery disease is inflammation, then in our clinical practice, you can have one indirect marker whether your patient is improving. HSCRP is a simple test which is available in your city. You can get it done at the time of acute event. And once you give the therapy, and with this therapy, the HSCRP level comes down, it shows that plaque which was unstable, which was vulnerable for rupture, is stabilizing. So far, no such studies have been done, but this is one gray area which can be taken up. And I think in India we have highest degree of re-stenosis, re-infarct, because of the non-compliance, poor country.
Many things,
So we can have quite a good
Yeah.
food for the work.
Yes, sir.
Yes. Thank you.
Thank you so
Thank you,
much.
Dr. Rao. Next.
So one question,
Thank you, sir.
excuse me, one question I want to ask.
Sure, sir, sure.
At the beginning of the lecture, you told that in being an Indian is indirectly a more risk factor for cardiovascular disease. And then subsequently in the lecture, there was the mention about risk scores, which are risk score tools, which are available online.
They're not for Indians, you're right.
So how can we interpret if an educated patient asks that these are my complaints, and doctor, can you tell me about how much I have? If I feed that information on the internet too,
Yeah.
so how can I interpret that result? Whether it is increased, say it shows 10%. So what do I tell to the patient?
So what the best answer which I can give to your question is use the risk score, apply those risk scores, you can give it to your patient, that is the minimum risk that patient is having for a cardiovascular disease. He will definitely have a risk higher than that. I'm sorry to say that we don't have a data, that's why we don't have our own risk scores. All these risk scores are mainly, most of the patients in them were the Western population. So the best is calculate the risk score, and what you can tell your patient is this is the minimum risk you are having or you will have that you will develop a cardiovascular disease in next 10 to 20 years. Another reason why you must be wondering, why do we have increase, why are we at risk for coronary artery disease being an Indian? One of them is LPA, which is called little lipoprotein. Another one is we eat high carbohydrate diet. I don't know, our diet is full of carbohydrates, we have high triglyceride levels. Another one is we might be having a bad form of LDL. Most of our patients don't have high LDL levels, but what we might be having is, rather than the quantity, the quality of LDL for us might be bad. I don't know. It has to be done by a spectrometry, and you calculate the density of the LDL particle. The smaller the LDL particle, it is bad. The bigger LDL particle is good, and the size of LDL particle can be increased just by exercise. Start jogging, walk, use stairs, don't use elevators. So these are small things, and I think our food is, somebody said that we kill our vegetables. So there are a lot of things actually. We fry, we do so many things. All our oil, even if we try to use the best oil, once we burn it, it's all trans fatty acid. So I don't know, it is all for us to kind of improve our health and improve the health of our society. Any other questions? Thank you so much.